Dr. Colvin, we were looking at documents around the middle of 1983 about the developing response to HIV. And we'd looked at the letter from Professor Bloom and Dr. Ritzer, June 1983. I'm just going to ask for that to go back on screen. Henry, it's BART 0000844. That might be the wrong reference. Apologies. Oh, it's the right one. Good. We'd looked at the recommendations. I'm not going to go back to those. But if we just look at the first paragraph, we can see what's being said there about, I suppose, relevant to an assessment of risk. So far, one possible case has been reported. This patient conforms to the definition published by the CDC in Atlanta, but cannot be considered a definite case. And then if we just go further down the page, please, Henry. Below the paragraphs 1 and 2 that we looked at yesterday, Dr. Colvin, we can see that it says it was agreed there was as yet insufficient evidence to warrant restriction of the use of imported concentrates, and reference is made to the FDA recommendations in March 1983. Now, would you agree that there's really comparatively little information in here to enable clinicians such as yourself receiving this to make a reliable assessment of the risk?
Yes, I would. I agree.
Henry, could we have up on screen next to this CBLA 00000, I think 5043 _040. This is the Galbraith letter that you referred to yesterday, Dr. Colvin. I thought it might be instructive just to look at them side by side if we can. So, in Dr. Spence Galbraith's covering letter to the Department of Health and Social Security, and we can see it's a few weeks before Professor Bloom and Dr. Ritzer's letter, 9th of May 1983, he says in the first paragraph, last week whilst you were away in Geneva, a case of AIDS in a haemophiliac in Cardiff who'd received USA factor VIII concentrate was reported. The case fits the recognised criteria for the diagnosis of AIDS. So we can see there already there is more information than we have in the UK HCDO letter. You know it's a haemophiliac in Cardiff from this, not mentioned by Professor Bloom and Ritzer. And you know it's someone who's received American factor VIII concentrate. And then we can see it goes on to refer to 3 cases of haemophiliacs in Spain having been reported in the Lancet, who've also received US factor VIII concentrate. And then in the same issue, the tally of 11 reported cases in haemophiliacs in the USA is recorded, and a paper describes a case in a multiply transfused child in the USA. So would you agree there's a lot more information relevant to an assessment of risk in Dr. Galbraith's letter?
Dr. Galbraith certainly has information which I wasn't aware of.
And then if we then go to the second page, Henry, of the Galbraith letter, please. And sorry, before we do that, I should perhaps just clarify. Dr. Ritzer and Professor Bloom obviously were providing a perspective as haemophilia clinicians. Dr. Spence Galbraith was director of the CDSC, so he had an epidemiological and public health perspective to bring to bear. And we can see his recommendation at the top of the page. I'll come back to the recommendation in a moment, Dr. Colvin, but we can see his recommendation is the temporary withdrawal of all blood products imported from the USA made from blood donated after 1978 until the risk of transmission of AIDS becomes clarified. And then I did want to go through his reasons with you, and I invite you to comment on them. So his first reason is that the AIDS epidemic is probably due to a transmissible agent. And you would agree that with that as a statement of knowledge at the time?
Yes.
His second is that it's an agent probably transmitted by blood and blood products, and then he sets out more details of a number of cases. Again, I think it's clear from your evidence yesterday you'd agree with that.
Yes.
His third reason, go to paragraph 3, Henry, is that although the number of cases of AIDS associated with the administration of factor VIII concentrate is very small in relation to the number of individuals receiving the product, this may not indicate that the risk is small. Again, you'd agree with that?
I can understand that very well, yes.
Yeah, and obviously from an epidemiological public health perspective, that's where his advice might be key.
Yes.
Point 4 then, please, Henry. Factor VIII concentrate and pool products would appear to have a high risk of being contaminated with AIDS, and that's because of the donor pool. And he goes on to say possible that the AIDS agent may be present in blood of healthy persons for several months before onset of symptoms. Again, you'd agree with those observations. And then paragraph 5, apparently no means of ensuring that blood or blood products are free of the AIDS agent. That was also true at that time.
Yes.
Point 6 is the mortality rate. Again, whatever the precise figure, known to be very high.
I understand.
So in terms of the actual factual matters he there sets out, you would agree with all of those?
But it's very carefully ordered and organised letter.
Now, I know you're aware of this letter now.
Yes.
Was it a letter, as far as you know, that was ever shared with haemophilia clinicians at the time?
The first time I knew about Dr. Galbraith's work was when the document was shown to me when I was preparing to give an interview for the Panorama programme in 2017.
So many, many years after
Yes.
the event. Could we go back to the top of the page of this document, Henry? So above numbered paragraphs 1 and 2. So next page. So we'll go back then to his recommendation, the temporary withdrawal of all blood products imported from the US made from blood donated after 1978 is proposed. Now, obviously, that kind of action's not an action that was in the gift of an individual clinician such as yourself. What, if any, observations do you have upon that proposal?
It was very bold and decisive.
If it had been implemented for, as Dr. Galbraith says, a temporary period, whilst seeking to clarify the issues in relation to AIDS, the implications in terms of treatment would presumably have been clinicians such as yourself would have had to adjust treatment programmes. Greater use of cryoprecipitate would have probably been inevitable as a response.
Not necessarily, but I'm happy to talk to you about it.
Please do.
So I think there would be two different sets of consequences. The first consequence would be, what do we do next? And I think you can see that from my own practice around that time, perhaps not quite half my practice was using commercial concentrate. But for some people, I think, although you'll know better than I do, more than half and maybe almost the whole of their practice might have involved the use of commercial products. Because I've explained to you, and I think it's clear even from the correspondence you produced for me this morning, that I was committed, rightly or wrongly, to the National Health Service and what it was providing for our patients. So let us assume for a moment that half the concentrate for the country would have disappeared. That's not a bad calculation. And in fact, if you look at the 1983 statistics, you'll find, I think, that half the product in the country is being NHS and half is commercial. So we're going to need to continue entirely on National Health Service product. I've already explained, and we've discussed, that if you have a patient having large quantities of cryoprecipitate, the chances are they will be at high risk of hepatitis C. And we know that the NHS, at that time, we thought that the NHS pool was not contaminated, which of course we were wrong, it was contaminated. So I think that your options are to try to withdraw to cryoprecipitate, as you were implying, which I think would have been exceptionally difficult, because one would have had to somehow build up the supply of cryoprecipitate, which, though not impossible, would not have been possible within a few days or even perhaps even a few weeks. So I think that the most likely response of UKHCDO would have been to use as much cryoprecipitate as we had, perhaps increase the supply of cryoprecipitate as you implied, But I don't think we would have abandoned the use of NHS concentrate. I just don't think that would have been in any way practical. And it wouldn't necessarily, particularly if it was the case that the NHS pool was not contaminated, it wouldn't have been harmful. Now, how would you manage a service that was suddenly cut in half? And I think the answer is probably an abandonment of all surgery except absolutely life-saving surgery. And I think the abandonment of the home treatment programme and a reversion to on-demand treatment only. And even with that, you might want to scale down the doses that you're using. Scaling down the doses perhaps for, and this could be controversial ethically, I haven't really thought about it through, but maybe you keep the doses for the little children the same and maybe sort of reduce the doses for the adults. I mean, I'm just purely speculating now in a very free way, and I'm not sure that what I'm saying necessarily makes sense, but I'm trying to think what one could have done. If you look at the position in India, Dr. Srivastava in Vellore, for many years, has done work on how to manage with a little bit of factor VIII. And I've already explained to you, or discussed with you, the fact that if you give a little bit of factor VIII, you get a massive bang for your buck, if you like. So that immediately, from nothing to a little bit, you get a fantastic benefit. And the benefit at the end is, well, significant, but, you know, it what makes the difference between somebody who's all right and fantastic, which is not the same as having somebody who's awful and surviving. So I think that if you had abandoned all surgery except for the most life-saving, and if you had abandoned the home treatment program, and if you had cut back on dosage and accepted a few deaths and some serious joint damage and some serious and very painful illness, you might have got away with it.
Yes. I'm not suggesting it would necessarily have been without consequences.
No,
I just wanted
but
to explore how it could be
share
done.
with you, just thinking about what you could conceivably do. The next thing, before we move on, and the second part of what I was going to say, was I wonder what difference that would actually have made to the final result. It's very interesting to hear Mark Winter last week saying that he tested all his patients that he was able to look at in, I think, the end of '84, because that's when the testing became possible, and they were all positive. Now, I don't know whether you want to discuss with me what he said, but what I would like to say is that he doesn't know, I don't think, because he said that he only took the blood when the testing became available, and then there wasn't blood taken beforehand. He doesn't know whether all those tests were positive on the day he tested them, or whether they were all positive on the day he started his unlicensed heat-treated factor VIII. And so what we do know is that probably by 1983, a very large number of those who'd received large amounts of, or even perhaps moderate amounts of commercial concentrate, were already HIV positive. And that process had started in 1980. So that the consequences of the temporary withdrawal of all blood products, in the way that Dr. Galbraiths perfectly understandably recommended, was a probable, I think, significant reduction in anti-HIV positivity, and a significant and probably very significant reduction in the quality of haemophilia care.
We've looked in these two documents at the UK HCDO perspective and Dr. Galbraith's public health perspective. Could we then just look at a communication from the blood transfusion service at this time? Henry, it's NHBT, you can take both those documents down, NHBT 0020668. Now, this is an internal National Blood Transfusion Service letter. I'm not suggesting you would have seen this at the time. It's dated the 6th of July 1983, so within the same span of weeks of the material we've been looking at. And it's enclosing a copy of a final form of an AIDS leaflet, which is going to be used in transfusion centres to try and reduce the risk of donors who might be HIV positive donating blood. Could we just turn to the next page, please, Henry? And we can just see what's set out there in terms of question and answers. If we could go to the bottom of the page, you'll see there's a question: can AIDS be transmitted by transfusion of blood and blood products? Almost certainly yes. There is only the most remote chance of this happening with ordinary blood transfusions given in hospitals. However, in the USA, about 10 patients suffering from haemophilia, an illness in which the blood will not clot, have developed AIDS. Haemophiliacs are more susceptible to AIDS because they need regular injections of a product called factor VIII. This is made from plasma obtained from many donors. Should just one of the donors be suffering from AIDS, then the factor VIII could transmit the disease. Would you agree with me that the answer that's being given there, again, is a very decisive, firm, unequivocal answer about risk being communicated, or the intention is within a few weeks, to donors?
Sure, I understand. I understand.
And a much clearer statement of risk or association between blood products, blood and AIDS than we see in the letter that was produced by Dr. Ritzer and Professor Bloom.
Yes.
Could we then we'll go on to look at some documents that you would have seen at the time, Dr. Colvin. Could we please have BART 0002284? So we've already looked at this document in part. It's the document co-authored by you and Dr. Kernoff in August 1983, Haemophilia Services in the North East Thames Region 1983. If we look to the next page, under the heading Summary, we see there's a reference to major advances in the management of haemophilia, and then reference to local regional arrangements and the role of the regional haemophilia centres. And then in paragraph 4, an issue there in relation to cost and the cost of commercial blood products and the importance of achieving national self-sufficiency. And then if we go to the next page, please. Sorry, 2 pages further on. My apologies, Henry. That's the one. So if we look at the 3rd paragraph down, where it says a fundamental problem in the UK that is that the NHS is not self-sufficient in blood products, we can see there a reference being made in this paper. Not only is this expensive, but there are long-standing concerns regarding possible health risks. At present, the benefits of therapy outweigh potential disadvantages. Now, there's no specific reference to AIDS there. I'm just going to show you what references there are to risks and then ask you a question. And then if we go to the bottom of this page, please, we can see at paragraph 1.4b, reference is made to the 2 particular complications of treatment, and one is plasma product transmitted disease, particularly hepatitis and possibly the acquired immune deficiency syndrome. An important function of haemophilia centres is one of regular patient health surveillance, which includes a commitment to public health. At present, this aspect of a haemophilia centre's work does not have an important impact on spending, although it does on workload. And then there's a reference to the possibility of hepatitis reduced concentrate. So there's a reference there to AIDS, but it's in fairly tentative terms. Would you agree?
Yes, I think that's true. Yes, of course.
And then I think that may be, and if we go to, sorry, there's one further reference. If we go on, Henry, if you look at the pagination at the top of the page, Henry, it's page 7 in internal pagination. It's probably page 8 of the document you have. Or page 9, possibly. Next page. And then we can see a further reference to hepatitis and AIDS at the top of this page, paragraph 3.3, impact of hepatitis and AIDS. There's likely to be an increased morbidity due to chronic liver disease, CLD, over the next decade. Whether this will result in significantly increased mortality will probably not be known for several years. Clinical problems related to impaired immunity seem to be rare at present, but conceivably could become a major clinical problem. So that last sentence, I think, is the reference to AIDS.
Yeah.
Now, that is, I think, the only discussion in this paper of HIV and AIDS. Now, I'm conscious the paper was in part a paper looking at issues of funding for the future. But is there any reason you can think of why you and Dr. Kernoff were not addressing more directly by August 1983 the AIDS risk?
Well, I think because we didn't appreciate what was going to happen next. And one can only read what we said, and I believe that we said it in good faith, but I can understand that you might think that more could have been said.
And then if we move on to the autumn of 1983, it's PRSE 0004440, please, Henry. So this is a meeting of the Haemophilia Centre directors on the 17th of October 1983, the big group meeting rather than the smaller meeting of reference centre directors. And we can see that you were in attendance at that meeting.
Sure, yeah.
Could we go to page 10, please, Henry? We can see in the second half of the page under the heading Any Other Business, Dr. Chisholm raises the problem of patients refusing to take up commercial factor VIII because of the AIDS scare. She wondered, in view of the worry of the patients, whether the directors could revert to using cryoprecipitate for home therapy. Then we see Professor Bloom's response. He felt there was no need for patients to stop using the commercial concentrates because at present there was no proof that the commercial concentrates were the cause of AIDS. Dr. Chisholm pointed out there was a further problem in her region because of problems in getting large amounts of commercial concentrates, whereas she could get unlimited supplies of cryoprecipitate. Other directors reported they had the same problems. And then after discussion, it was agreed that patients should not be encouraged to go over to cryoprecipitate for home therapy, but should continue to receive the NHS or commercial concentrates in their usual way. So do you have any recollection of this discussion or Dr. Chisholm's intervention?
Well, I knew Dr. Chisholm very well, and I think I can just about remember her intervention in the sense that I remember she was there and she said something, but I don't remember any more about it than that.
Do you recall whether you were in the category of directors who were in a similar position to her? She had problems getting commercial concentrates but could get unlimited supplies of cryoprecipitate.
I find it quite difficult to believe that she truly was able to get unlimited supplies of cryoprecipitate. I can't believe that anybody would be able to get unlimited supplies of cryoprecipitate. Getting large amounts of commercial concentrates, I mean, my memory, if you were prepared to get the commercial concentrates in, they were available to you. So I don't quite understand that sentence, really, any of it, because I don't understand the difficulty in getting large amounts of commercial concentrate, if she's prepared to find it.
But that may be a funding issue, of course.
Of course, it could be a funding issue. And I don't really understand the concept of unlimited supplies of cryoprecipitate, because you've got to collect the blood for the cryoprecipitate and put it in the freezer, and it has to go somewhere. And to provide unlimited supplies would be a logistic challenge for any transfusion centre. And it's important to remember that the cryoprecipitate is a transfusion centre product, whereas the concentrates are a Elstree or commercial production facility.
Yes. I mean, what might precisely be meant by terms such as unlimited, the clear thrust of what Dr. Chisholm was saying was, I am in a position to use cryoprecipitate rather than commercial concentrates. What do others think of this suggestion?
Obviously, there's the issue of home treatment, because I think she's mentioning home treatment here. And as we discussed yesterday, although I've done cryoprecipitate on home treatment, I wouldn't recommend it. And I think it would have created huge difficulties for patients for the reasons we discussed yesterday. And I think we also discussed yesterday the fact that some of us, including myself, and this would have been around this time, I think, were trying to use cryoprecipitate where we thought it was appropriate. But we also have to acknowledge, as we discussed yesterday, that cryoprecipitate is also capable of transmitting either hepatitis C or HIV, although you only have one unit at a time, although you might be using 10 units for a single dose.
Was Professor Bloom right, in your view, to say that at present there was no proof that commercial concentrates were the cause of AIDS?
No, I think this is, is it October 83?
October 83.
So this seems to me to be more wishful thinking, if I may say so.
The agreement that's recorded at the bottom is essentially no action. Don't encourage your patients to go over to cryoprecipitate. It's not even left as clinical freedom for the individual clinician to decide whether to encourage their patients to do that. Patients should continue to receive the NHS or commercial concentrates in their usual way. Does that surprise you that no slightly bolder recommendation was being made by that time?
Well, I think at my personal level, it was always my choice to use NHS concentrates where I was able to do so, and I only bought commercial concentrates when I had to. I think that's in the papers that you've just handed me this morning. As I've said, there were others who didn't care much for the NHS or its product, and I suspect there may have been places where commercial concentrate was actually dominant, and therefore I think that there may have been some concern that were there to be a change in the recommendation, it would create enormous difficulties of the kind that we've just been discussing.
But this is effectively just maintain the status quo with no change whatsoever, yes. Which suggests to you is I'm conscious of you're answering by reference to your own practice, and we'll come on to look at that. But as a general recommendation from UK HCDO, it is surprising to see no recommendation for change by October 1983. Would you agree?
Yes, and in fact, in retrospect, of course, if it had been that Dr. Galbraith's recommendation, whatever its difficulties, had been implemented, there would have been a great deal of clarity, and we would have had a completely different problem to deal with.
Yes.
And we would have no doubt in some way dealt with it, but it would have created a whole range of new problems that we would have had to address.
And then just looking again now at some documents local to you and the London hospital and your policies there, could we have, first of all, Henry, IPSN 0000584_003? Could we go to the first page of that, please? Thank you. So we can see here, this is a report. It's looks like it's a UK HCDO authored report. We don't have a precise date to it, but it's looking at data between 1981 and 1983. And if you take it from me, it's then got some incomplete data from 1984. So it looks most likely as though it was a document produced in 1984.
But it's about inhibitor patients.
It is about inhibitor patients, absolutely.
Which is in itself extremely important. I have been sent this document, I think, but I think it's important to note that this is about inhibitor patients.
Yes, no, absolutely. This is just one small part of the jigsaw.
Okay.
I just wanted to ask you about something about your treatment of inhibitor patients on the basis of this. So if we could go, please, to page 9, Henry. And the document looks at policies and approaches in different centres, and I just wanted to ask you about yours. So this is London Hospital. Dr. Colvin has 6 inhibitor patients, 3 of whom are low responders, 2 are high responders, 1 has spontaneously acquired antibodies. His policy is to give human factor 8 to all the patients for all bleeds, and if that fails to use porcine factor 8, he's treated 2 patients with high 8C to date, 1 congenital, 1 acquired. So the first question is that a correct statement of your policy at the time?
I think it must be, although I could comment on some unusual aspects of it, but I think it illustrates my commitment to NHS concentrate and to human concentrate rather, perhaps, if I can avoid it, than FEBA. But the difficulty with what I've said is that if you've got a high responding patient, the factor 8 concentrate isn't going to work. So you can give as much human factor 8 as you like to somebody who's got a high responding antibody, and it won't work. Of course, I've said that I've got 3 low responders and 2 high responders. So for the low responders, it's possible that it actually will work. For the high responders, if the antibody against porcine factor 8 is sufficiently weak, then I would certainly use porcine factor VIII, because I was able to get a measurable response in the laboratory. Because what happens if you've got an inhibitor that is of moderate intensity, the intensity of the inhibitor will be lower against porcine, because it's moderately high against human. Then you give the porcine factor VIII, you can measure the factor VIII in the circulation, and you get a clinical response which is proportional to the laboratory response. So if you can use porcine factor VIII, you've got a really measurable response which reflects clinical practice. However, if you're going to use something like FEBA or Autoplex, which I never used, this is an activated product which hasn't got any units associated with it that are actually meaningful. I mean, they gave quoted units, but those units were correctional units. They weren't real units. So you've actually don't know what you're doing. So you give a very expensive and very potentially toxic product to somebody, which you hope will stop the bleeding. Now, that's worth it if your patient's bleeding to death. But if you can get control with a product which does give you a measurable response which is proportional to the clinical effect, that's fantastic.
And is there any particular reason why by 1983 porcine factor VIII would not have been the first port of call over human factor VIII in light of the AIDS risk?
Well, it was quite idiosyncratic as a treatment. Peter Kernoff was an expert in porcine factor VIII, as was Christopher Ludlam. And it was particularly useful, actually, for acquired haemophilia. Maybe we don't need to discuss acquired haemophilia, but acquired haemophilia occurred in old, normal people who got an antibody to factor VIII and then started bleeding. And porcine factor VIII was particularly good. Nothing to do with haemophilia itself. They got acquired haemophilia. It was an autoimmune response in a normal person, nothing to do with the congenital haemophilia. But I think I was all influenced by Peter Kernoff. And the fact that Peter was an expert in this area meant that I was also very interested in it, and I would have used porcine factor VIII for the reasons that I've suggested. However, it was very allergenic. It caused a lot of allergic reactions. It was very likely to cause a fall in the platelet count, thrombocytopenia, which could be dangerous. And it may well be that some people thought that this was an idiosyncratic treatment that didn't warrant use.
Could we then go on to BART 0000517? So this is a document I know you've only seen this morning, Dr. Colvin. It's a letter dated the 23rd of March 1984, and it's authored by you. It's to the London Hospital's District Supplies Officer, and it's really just to flesh out some of the evidence you gave yesterday about what products were being used when. So we see there, in paragraph 1, you're using NHS factor 9, paragraph 2, as you've just said, not using Autoplex. You've referred to using FEBA once. And then you say in paragraph 4, our use of imported factor 8 is entirely dependent on the supplies of NHS material. Our usage over the last few years has been. And then we can see there the figures set out for 1981 and 1982, where we don't have the returns. And then 1983, we've already looked at because we had the 1983 return, and the figures are consistent. We can see that in 81 you were using a small amount of Highland, a larger amount of Armour and a much larger amount of Immuno. In 1982, no Armour, again a large amount of Immuno and a reasonably large amount of Highland, certainly an increase on the previous year. And then in 1983, there is a drop in the amount of commercial concentrates being used to the figures we looked at yesterday. But just ask, first of all, can you recall how you made the decision, or you and your colleagues at the London would have made the decision as to whether to purchase factor VIII in a particular year from Immuno rather than Armour or Highland rather than Qatar?
I really can't. What I think we did agree, and this may have come out elsewhere, was that it was always a good idea not to have one supplier only. I don't think there was any evidence that any particular product at that time was superior to another technically. So I think price would have been a feature. But you can see that although I said I'd like to have 2 suppliers. You can see in 81 I clearly had 3, and in 83 I had 4. So, although very small amounts of hydrogen and armour. So I don't know the answer to that question. Of course, some of it might have been that there were people visiting the centre who were using a commercial product and sent in a return for a commercial product, might even conceivably have been supplied elsewhere. I don't think it's very likely, but I'm a bit puzzled by these levels of 4,000, 3,500 and 5,500. They're very small quantities. I mean, not much more than you'd use for a single bleed. So I really can't entirely explain that. But if you ignore those, well, I'm not suggesting you ignore them, but if you take them out of the equation, it does look as though in those circumstances I'm using 2 suppliers. But I don't know why.
The decision as to which commercial products to purchase, was that a decision taken largely by you and Dr. Kernoff for the region, or was it done by others within the region?
I would have thought that it would have been Peter and myself, generally speaking, and I would have expected for me to be the person who chose what to buy for the London hospital. But I can't explain these figures, really.
And then if we just go further down that page, we see that you refer there to the reduction in commercial concentrate purchase in 1983, and the explanation for that is it was almost entirely due to an increase in the supply of NHS material, and the annual consumption of all forms of factor VIII fairly steady at about 1.5 million units a year. Sure. So it would seem that in the course of 1983, you've been able to use less concentrate because you've got more NHS available. And
that would fit in with my overall philosophy.
And then could we please have BART 0002310, please? Again, Dr. Colvin, I know you've only seen this letter this morning. 22nd of February 1984. It's a letter from you to Dr. Waters at the Haemophilia Society. And it's obviously part of a chain of correspondence with a document that you've been asked to comment on. And I'm not going to ask you about most of the detail of it, but there's just one comment I wanted to ask you about. If we go to the second page. You say at point 4 this: I agree, so you're agreeing, I think, with what Dr. Waters, Mr. Waters must have said, or what the Haemophilia Society document must have said, that we know little about AIDS at present. In my opinion, there's no reason to spurn commercial concentrate, and we have to keep an open mind on the risk associated with NHS material. Can I invite you to comment upon that? Because it seems to suggest that you don't think there's an increased risk from commercial material in relation to AIDS, as at Feb 84.
I don't think that follows. I think what I'm saying is that I believe we know little about AIDS at present. That seems a statement. The question is whether we spurn commercial concentrate, and the advice from UKCDO and from our discussions is that it is not appropriate at the moment not to use commercial concentrate. I'm also pointing out that we're not entirely clear, and it's going to be very difficult to know whether there's a risk associated with NHS material or not. So I think it is what it is, and the word spurn, I suppose, implies that I am not, from the evidence that's presented to me, recommending that we don't buy commercial concentrate at all. I realise that's what it means.
And then if we can go on in the course of 1984 to another North East Thames region meeting, it's BART 0000677. This is a document you'd already seen, Dr. Colvin. So these are the minutes of the Haemophilia Working Party of the North East Thames Region Association of Haematologists. This is 9th of May 1984, and you're present, as is Dr. Kernoff. Could we just go down to the second page, please, Henry? And we can see halfway down the page is an update on AIDS, and it says this: Dr. J. Harrison, that's Dr. Jean Harrison,
yes.
who was the director of the Brentwood Regional Transfusion Centre.
Following Dr. Jenkins' retirement.
described the efforts made by the BTC Brentwood to exclude at-risk donors by information and leaflets distributed to donor sessions. It was noted that commercial suppliers also are now applying similar criteria in their donor selection. Heat-treating concentrate has been tried but reported to cause loss of potency. So that's, I think, an update from Dr. Harrison. And then it says this: it was suggested that until a positive test for AIDS and/or a vaccine is developed, it should be policy to avoid use of blood products except for essential treatments, and to use cryoprecipitate or plasma instead of factor VIII concentrate whenever possible. Now, it's not entirely clear from the minutes whether that's a suggestion from Dr. Harrison or someone else.
I don't know.
And it's not clear whether that's a suggestion that is then agreed by others.
Sure.
Did that become the London Hospital's your policy in May 1984?
I don't think it did specifically, no. I mean, I can't say that there was a specific policy in 1984 that should be the case.
And then the reference there to essential treatments, do you know what was being encompassed in that concept?
No, I don't. But I'm obviously it doesn't have a specific meaning.
So it maybe that was a suggestion rather than a policy that was adopted.
It seems. I mean, again, it is what it is. I understand what it says.
But you can't recall any particular change in your own practice
No.
at the London Hospital after May 1984.
No.
And then if we move on to late 1984, December 1984, Henry, could we have HCDO 0000394_117? Now, this is a meeting, not one at which you attended, Dr. Colvin, but this is a meeting that we know took place on the 10th of December 1984 at Elstree. It's recorded here as being a note of Haemophilia Reference Centre Directors meeting, but we can see there are a number of others who attend, including representatives of BPL and the PHLS, Dr. Tedder and others. I'm just showing it to you to show that we can see Dr. Kernoff in attendance.
Yes.
That's the 10th of December. Now, that resulted in the production of a document that you would have seen, and we'll look at that next, HCDO 0000270_007. So this is a document called Haemophilia Centre Directors Organisation AIDS Advisory Document. It was dated the 14th of December 1984. And our understanding is it was sent out, we're not sure of the precise date, to Haemophilia clinicians. Do you recall receiving this?
I don't recall this particular document being received, but I recall December 84 very, very well indeed.
Oh, and if we just look at the second page of the document, just so that we can see what was being recommended or suggested, we can see that if we go towards the bottom of the page, under the heading Options in Probable Decreasing Order of Safety for AIDS for Haemophilia A, we've got heated UK concentrate as being the preferred option. It's noted it's still a risk of non-A, non-B hepatitis. Second option, single donor cryo or FFP. Third option, heated imported concentrate, still a non-A, non-B hepatitis risk. 4, unheated UK concentrate. 5, unheated imported concentrate. And the observation there is almost certain to be contaminated. Would you agree with me? That's, I think it's clear from the heading, that's a set of options where safety is now the fundamental criterion that's informing that.
So obviously it says probable decreasing order, so we don't know for certain.
No.
And I mean, I can remember this as if it was yesterday in December 84, when I sit in my office with my head in my hands talking to Peter Kernoff saying, what on earth do we do next? Because I think we'd reached really rock bottom in December 84 of our understanding and our power to deal with this crisis. And I think really from January 85 onwards, we began to address the problem and begin to get it right. But you're going to show me some documents which show that there was uncertainty on the relationship between 3 and 4. That is, heated imported concentrate and unheated UK concentrate.
Yes.
That was a big dilemma.
Yeah, and we'll look at that in a moment. We'll just go towards the bottom of the page and then the top of the next page. So we can see then the recommendations, concentrate is still needed. Bleeding is the commonest cause of disability and death. 2, use DDAVP in mild haemophilia A and von Willebrand's disease if possible. And then we can then see the recommendations in relation to haemophilia A. It's cryo or heat-treated NHS factor 8 if available, and we'll see the issue in relation to availability of that in a moment, for children and virgin patients, those not previously exposed to concentrate. And then heated LHS factor 8 if available, or heat-treated commercial for severe and moderate haemophiliacs who don't fall within the groups already identified. And then haemophilia B, fresh frozen plasma or NHS factor 9, essentially for mild virgin, those not previously exposed, and then just NHS factor 9 for those who previously used it. So those were the recommendations, but if we just look a moment further on, we can see it says in individual patients there may need to be a choice. In general, heat concentrate appears to be the recommendation of virologists consulted, but individual directors may wish to make up their own minds. This is particularly true of unheated NHS material. So still being left to the judgment of individual clinicians exercising clinical freedom.
Well, I think one can put too much emphasis on the concept of clinical freedom. My feeling here is that we are looking at a series of questions to which there are no answers. The success of heat treatment depends on, 1, the donor pool, 2, the size of the pool, 3, the method of viral activation. And all of those are critical in what happens next. Now, obviously, it's possible later that the donor pool is affected by tests for HIV, but at that time, it would have just been the donor pool with or without donor selection. And we know that the commercial people have been actually trying to improve their donor selection. So those 3 issues will determine the safety of that product. You can't just talk about heat treatment. There are lots of different types of viral activation which were being tried out at the time. As you know, there was anxiety that the effect of the heat would actually damage the factor VIII molecule and might reduce yield, which it did. It was also feared that this treatment would damage the molecule in a way which might result in inhibitor formation. And most importantly, there was anxiety that the heat treatment wouldn't work. Now, why would we think that the heat treatment wouldn't work? Well, all the work that had been done so far on hepatitis C, which of course wasn't known about hepatitis C, which was non-A non-B, suggested it didn't necessarily work. And although we now know that HIV is more heat sensitive than HCV, we also know that in 1986 and 1987, a number of people in Canada and in Birmingham, UK, were infected with HIV from a heat-treated concentrate. So I think we were in an impossible situation. And this list, which is perfectly understandable and logical, is just a list of what is thought by one or more individuals to be the case. Certainly in my own mind, I was very concerned that if I use heat-treated commercial concentrate and it wasn't virally inactivated, I would infect a large number of my patients who were not yet infected. And at some point, I'd like to discuss what Dr. Winter said in his evidence about the early heat-treated concentrates. Because I know that many of my patients were not HIV positive. And if I had given them all a heated commercial concentrate, which was actually transmitting HIV, I would have transmitted HIV to a very large number of my patients who were so far uninfected.
Can we look then at what was done locally with the London Hospital after this set of recommendations was produced? So if we could have first, please, BART 0000676. So we can see this is another meeting of the North East Thames Region Haemophilia Working Party. It's the 13th of December 1984. So that it's 3 days after the meeting, which the recommendations have been agreed, but it's before the document that we've just been looked at has actually been finally drawn up. And we see again you and Dr. Kernoff are there, along with a number of others, including on this occasion as well from the Royal Free, Dr. Tuddenham. If we go to the second page, please, Henry, we can see update on AIDS. The first paragraph there is the American experience suggests that the risk of AIDS in treated haemophiliacs is 1 in 300. It appears to be less than 1 in 800 in treated patients in the UK. Now, I'm not clear what the basis for those statements was. Do you know?
No, I don't know.
Do you agree it doesn't necessarily appear to be correct in terms of an analysis of risk?
Well, I think it illustrates a level of ignorance that we all suffered from.
Is it perhaps equating incidence with risk?
It might well be, but as I fear, we all know that the words incidence and prevalence sound the same, but they're very different. Incidence is when things happen, and prevalence is what's in the cooking pot.
And then we can see that the next paragraph suggests that a survey of 1,000 treated haemophiliacs in England and Wales shows that 30% are, it says HTCV, I think that must be HDLV3 antibody positive. The percentage may be higher in some centres. Exposure to commercial factor VIII concentrate in the last 2 years may be a significant factor. Do you know what the source of that data was?
No, I don't. I mean, the chances are, which year are we in now? We're in
This is December 84,
aren't we? Well, of course, the testing has only really just started. This almost certainly comes from Richard Tedder. And interestingly enough, it might come mainly from his centre, because the Middlesex has a number of people with haemophilia in it. It's not a big centre, but it may well be that and this is pure speculation now, but it may be that the people in the Middlesex Centre might be tested quite quickly by Dr. Tedder because he's in that area. And if that was the case, then it wouldn't perhaps be surprising that not so many of them are anti-HLV3 positive because they are not big treaters.
It may be worth we just look at the previous page and see who was there, and perhaps you can just tell us where some of them were from, because you may recall the names. Do you know where Dr. Bolton Maggs was based at that time?
I think Paula was at the Royal Free at that time. She was doing work. I mean, she was a clinician. Of course, she's been had a very distinguished career since. But I think she was doing work on factor 11 deficiency, which is particularly prevalent in the North London Royal Free community.
Dr. Boots, I think, was from
Colchester.
Dr. Colvins, yourself. Dr. Edwards.
I don't know. Dr. Edwards doesn't ring a bell.
Dr. Harrison is Dr. Jean Harrison from the Regional Transfusion Centre. Dr. Mills.
Southend.
Dr. Oakey.
That's Orsett.
So the Essex.
Yes.
Yep. Dr. Oxley.
Harlow.
And Dr. Traub.
Southend.
And then we've got Dr. Tuddenham from the Royal Free.
And Sister Tubridy is my domiciliary nursing sister, who's the person who looks after haemophilia throughout the region.
So if we go back to the second page, thank you for that, we can see it said the clinical significance to those found to have HDLV3 antibodies not yet known. And then it's explained that BPL hoped to have heat-treated factor VIII concentrate available from April 1985, and that heat-treated factor IX should be available later in the year. And then there's the reference to a particular concern about the effect of heat treatment on factor IX concentrate, and a further discussion in relation to factor IX. And then we go to the next paragraph, we can see what's being agreed as at the 13th of December. Emergency stocks of factor VIII concentrate held by associate centres should be exchanged for a heat-treated product via the Royal Free. So that's the smaller centres in the local area. And then 2, heat-treated materials should be used whenever possible, with the exception of the NHS factor IX concentrate. So, well, actually, we'll look at the whole thing. 3 is all new patients and mild haemophiliacs with injuries requiring maintenance of high levels of factor VIII should be treated with heat-treated NHS factor VIII or small pool factor VIII concentrate pro tem if treatment with cryoprecipitate or DDAVP is not possible. So just trying to unpick, sorry, Henry, if we just keep the bottom of the previous page for the time being. So bottom of that page again. If we just try and unpick the recommendations there, that heat treated as a matter of generality is the express preference whenever possible. Is that a reference to supply?
Well, not necessarily. I mean, I think you're going to probably ask me later about the way we used NHS unheated factor VIII during the small transition period, and I've already addressed my concerns about the risk of NHS unheated versus commercial heated. So I think I mean, I've already dealt with that part of the discussion, the small pool factor VIII concentrate, which is being described, I think is the product that I used in the paper that I've submitted, which was Professor Machin was the first author, and I looked after 2 patients, and that shows that there were tiny amounts of an NHS small pool heat-treated concentrate available at around at that time, probably in the middle of '84, rather before this decision was made. And of course, the new patients and the mild patients were obviously had a certain priority. But I'm not aware that by December '84 there was really any heat-treated NHS factor VIII available, apart from my knowledge of the small pool, rather gently heated concentrate that I knew about and had obtained for my two patients.
So we can see there's a slight difference of emphasis between points 2 and points 3 here. New patients and mild haemophiliacs falling within the description there, it's cryoprecipitate or DDAVP, and if cryo or DDAVP is not an option, heat-treated NHS or the small pool factor VIII concentrate. There's no whenever possible or aspiration or aim. It seems to be a clear statement that's what the policy should be for those categories.
Obviously, that's what it says. I mean, I think that when people are drafting their minutes or when they're making their statements, they don't always know that 40 years later, every word they've used will be dissected.
No, understood. It's just this is the best guide we have.
Yes, of course. No, I'm not complaining. I'm just saying it's very difficult to interpret individual words at 40 years distance.
And the position of children's not expressly addressed there.
Well, the chances are that most of the children will be new patients, if you like. But I take your point that the children do have a very high priority, and that's I think a very fair point.
And then if we just go to the top of the next page to complete the picture, there's a reference to family members not volunteering as blood donors, and then elective surgery being delayed until the position is clearer and the efficacy of heat treatment proven.
Which I think is the first time that's been mentioned.
It is. So is it fair to infer that course, delaying elective surgery for the reasons they're given, was a new measure being adopted around this time?
I think it was, and in fact I happened to have, because of one of my Rule 9 questions, I happened to trip over correspondence with my surgeons in the very, very late part of '84, where I postponed an operation because that was the recommendation. Not necessarily this recommendation, but clearly we've been talking about it, and so I contacted my surgeon and said, let's wait. The difficulty with that decision, by the way, is that when would one be able safely to perform a surgical procedure? And I think the answer to that question, if you'd like me to give it to you, is probably 1988. And the reason I use that date is that that's the date when the 8Y study is published. Even that is not a proof that 8Y was safe. It's only a probability, but it's at the level of probability of around 90%. So I think that really from 88 onwards, published work that is safer or reasonably safe to perform elective surgery.
And then, can I just ask, what, for those who were on home treatment at the time, what was the process that was put into place at the London Hospital to try and get back any stocks of what may have been untreated commercial products?
I don't recall that, I'm afraid.
Would you expect there to have been a process?
Well, it's likely. I mean, I think we saw yesterday that I was using some commercial product in home treatment, but I don't know who it was for and why it was being given. So yes, you would have thought so. By the way, if we're talking about recalling product, I can remember the most dramatic event of recalling product was at the time of the 1986 World Federation of Hemophilia meeting in Milan, when we got the message that a particular commercial heat-treated product was transmitting HIV, and that really caused enormous alarm.
I'm slightly out of sequence, but I might as well ask you about it now. I know you gave evidence to one of the other inquiries about it. As I understand it, you were at the conference in Milan and received information at the conference about the issue of transmission from heat-treated concentrate. And what steps were then taken?
Well, I phoned home immediately and said, get this product out of the fridges and out of the patients immediately.
So I note the time. Is that a convenient point at which to stop?
Yes, it is. We'll meet again then at 20 to 12.